Good evening, and welcome to our first of a series of BostonSight Scleral webinars for this year, 2019. My name is Alan Kwok. I'm an optometrist at BostonSight, and I just want to welcome you for this next hour, where Dr. Elise Kramer and Dr. Stephen Sorkin will be speaking about and sharing about some of their clinical experiences and insights. Just as an FYI, this webinar is being recorded, and at the conclusion, we're going to share with you a link of the recording afterwards, just in case you want to revisit some of the things that were mentioned here. As I mentioned, Dr. Kramer and Dr. Sorkin are going to be kicking off our series this year tonight. Dr. Elise Kramer is a residency-trained optometrist who works in Miami and Weston, Florida, and she specializes in ocular health and disease, ocular surface disease, and regular and specialty contact lens fitting. Her doctorate degree was awarded in optometry from the pardon my French, Université de Montréal in 2012. She then completed her internship in ocular disease at the Eye Centers of South Florida and went on to complete her residency at the Miami VA Medical Center. Her time there included training at the Bascom Palmer Eye Institute, and after her residency, Dr. Kramer became a fellow of the Scleral Lens Education Society and now serves as the Public Education Chair elect for the SLS. Dr. Kramer is a member of the American Optometric Association and a fellow of the American Academy of Optometry. Dr. Stephen Sorkin is our second speaker tonight, and he is director of the Specialty Contact Lens Services at Corneal Associates of New Jersey in Fairfield, New Jersey. Dr. Sorkin currently serves as president of the Essex County Optometric Society and has previously served as a member of the board of directors of the New Jersey Society of Optometric Physicians. He is a member of the Medical Advisory Board of the International Keratoconus Academy, a fellow of the Scleral Lens Education Society, and he was named New Jersey Optometrist of the Year in 2018 by the New Jersey Society of Optometric Physicians. So that is by way of introduction. And sorry, let me get back here. And these are just quickly some financial disclosures of Dr. Kramer and Dr. Sorkin. And with that, I'll hand it over now to Dr. Kramer, who will start us off tonight.
Hi, everyone. Thank you to BostonSight for this great invitation. I'm really honored to be here with you all. And I'm going to jump right into it by talking about scleral shape. So it's no secret, we know that the sclera is asymmetric. It's a non-rotationally symmetric surface, or just simply said, asymmetric. And, scleral lenses that are landing on this surface, I mean, technically they are landing on the conjunctiva, but the conjunctiva doesn't really have much structure. So, Tenon's capsule, sclera, which are under the conjunctiva, are going to be the really clinically relevant structures that can be affected by our lenses. And so we know, and we've known this for a long time, that the scleral shape is a unique shape, and actually it's not a sphere, it is not symmetric, and it is shaped like a hyperbolic paraboloid, which is similar to the Pringles chip that we're all familiar with. And so it just seems unrealistic to fit a standard scleral lens on a surface that looks like this. And so we've started to realize a lot from patient complications and also through studies that and we need something that fits these surfaces better. And, why not start with something that is evidence-based design? So the BostonSight is an evidence-based design that was conceived based on data from over 7,000 eyes. And these lenses actually have elements of scleral shape built into them. So this makes the fitting process smart, fast, predictable, and it just makes the whole process a lot easier and simpler and better for the patient. So basically, all these lenses that were designed by BostonSight, and this is what the diagnostic set looks like. So these lenses were designed based on all this data that was collected from patient objective outcomes from the study that was done on these 7,000 eyes. And so these are anatomically based lenses. So they have elements of anatomy into them so much that we have a different lens for the right eye than we do for the left eye. And we know that, no two eyes are the same from patient to patient, but we also know that the right eye is different from the left eye. And I think it's great that this lens actually takes that into consideration, the anatomical differences between both eyes. And basically, when you look at the right eye, um,
Not advanced.
yeah. So when we look at the right eye, we can see that there's a one dot on the right lens, and we can see that there's a two dots on the left lens. And so this helps the patient, So this helps the patient and the practitioner differentiate between both lenses. And that's important both for follow-up and also for the patient to be able to use the lenses comfortably. So when we look at BostonSight lens, we also have this unique laser engraved model number that is really important. And you're going to find this right on the lens, easy to read under a slit lamp. And each character in this code is actually really important. So the first one is going to talk about the lens series. The R, it'll either say R or L here for right or left. The 8.5 in this example is telling us that this is an 18.5 millimeter diameter lens, and there's also obviously 18.0, so you would have 80, or 19.0, so you would have 90. The lens number, so if you go back to the set, you could see that they all have a number, and this is 1, 2, 3, 4, 5, etc. So you can see here this represents a lens number, and this final number here is the front surface eccentricity. So when you look at a BostonSight lens on the eye under the slit lamp, you'll see this number here, and that is very useful, again, for patient follow-up, especially during the fitting process when they're going to have, several lenses maybe at one time. We want to make sure that the patients are wearing the right lens, and this is really the way to do it. So when you look at this dot here, I mean, in this diagram here, it's at 12 o'clock. It's not always going to be like that in the patient's eye. And it doesn't really matter where this dot is. These are quadrant specific, toric designs. And so what you can do is just look where this dot is on the eye, where the different numbers are, and see what you have to modify. And then just log into Fit Connect and modify that quadrant the way you want to, and then send that information over to the lab. So again, it doesn't matter what the orientation is. You just have to see where the number is on the eye and then modify those quadrants as needed. So again, going back to this fitting process, so this is the fitting algorithm that is based on all the data that was collected. And so it's very simple. BostonSight recommends to start here with lens number 5, and this is the standard distribution lens. So basically, this has a SAG of 2.8. You put this lens on the eye. This is for the right eye, and obviously you have the one for the left. But if you need to increase in your sagittal height, you'll go higher, and if you need to decrease your sagittal height, you'll go lower. And most of the time, you're just gonna stay right here in this middle area. But if you feel like it's too loose and you want it to be a little bit tighter, you would go with a steep distribution. But if you feel like it's too tight, you would go to the flat distribution. So these different distributions here, steep, standard, and flat, have actually nothing to do with base curve. This is talking about the back surface, toric, haptic only. And so this is talking about the quadrant specific toric toricity that you are modifying in these lenses in order to improve the fit of these patients. And then you look at these two lenses here you have on the side, and these are exactly the same as lens number 5 in sagittal height, in everything, except the only difference is that the front surface eccentricity is different. When BostonSight created this lens, they again collected data from over 7,000 eyes, and they determined that the predominant eccentricity preferred by all these patients was actually a front surface eccentricity of 1. And this is along the whole spectrum of diseases that were being treated with the BostonSight lens, or with the pros lens at that time. And so the eccentricity is something that actually was being leveraged in the pros lens for years. And so they use that data to determine what is the most preferred eccentricity. And it was found to be an eccentricity of 1 in patients who had ectasia, in patients who had SJS, exposure, dry eye. It was predominantly an eccentricity of 1. But you also have lenses here that have an eccentricity of 0, for example, or an eccentricity of 2. And to determine which lens you want to use, it really depends on the patient's vision. So let's say, for example, you have a patient who with this lens is seeing 20/40, but they're pinholing better, and then you do an over refraction on this patient and you can't quite get to where that pinhole is taking you. So let's say they pinhole to 20/25, but with a spherocylindrical over refraction, you're only getting them to 20/30 and they're still complaining of glare and halos, then you might want to change the eccentricity. And in general, there's not really a direct, linear correlation, but they found that patients who had ectasia and still had glare and trouble with the eccentricity of 1 did better with an eccentricity of 2, while patients with dry eye or transplants, actually, they recommend to remove the eccentricity. So that's kind of like a cheat sheet type of thing, but it's case by case. So again, these lenses that you have here are not really for fitting, they're for over refractive purposes only. And I think that's really cool that they're actually in the fit set, because you can actually, it seems like based on this algorithm, you can really just fit your patient right there, then and there in the first consultation. So that makes it simple and easy. So going back a little bit to scleral shape, so we know that, again, the sclera is usually toric in shape. And this is a great example. If you look here at this OCT on the side, this is an OCT, anterior segment OCT of the same eye. And you can see how much larger the sagittal height is here, how much more curved it is at 90 degrees than it is at 180. And so this is going to make a huge difference. If you put a standard scleral lens on an eye that has such different toricities, there's such different curvatures in 2 meridians, then you're going to end up with a really angry looking eye and a patient that's just not happy. So if you put a standard lens on this eye, you're going to get this severe blanching vertically, and you might also even get edge lift temporally and nasally. And that edge lift is going to be not only uncomfortable for the patient, they might get bubbles under the lenses as well. And this blanching that you have vertically is just going to lead to rebound redness and overall soreness and discomfort. So definitely need something with toric haptics in actually most patients. And it's been shown, in several studies that having quadrant-specific haptics definitely can improve ocular health, improve comfort for the patients. These photos here again show edge lift. mild impingement, severe impingement, and an ideal fit here on the top right. And so you really want to go with quadrant-specific haptics in most of these patients. And again, the BostonSight lens has elements of scleral shape built into it, has quadrant-specific haptics. And when you want to modify a quadrant, you can modify 1, 2, 3, or all 4 of them as you want to. And so that makes it really great for customization. Other than Fit Connect, which is a feature provided by BostonSight, which allows you to log in, modify your lens, it really gives you control over the fit, over the design of the lens that you are creating for your patient. But they also have these really cool other features that I wanted to go through. So first, PeerMed, and that's something that's new. It was actually just released at the GSLS. This is a free app that you can download on any smartphone. It is a HIPAA compliant app where the information is encrypted, and it allows you to actually it allows a live consultation approach. So it allows you to communicate directly with a consultant who can actually see into your slit lamp. So what you have to do is just get one of those simple adapters for your smartphone, which a lot of you probably have, that we use to take pictures, and actually just put that on the slit lamp. And using this free app allows the consultant to actually see firsthand what's going on. And this allows you to really streamline the consultation, allows to troubleshoot anything. It's like if you had a consultant right there in the room with you. So that is really, really cool. The eaglet, so the eaglet is going to have the algorithm for first fit available, I think, in the month of March. So that's going to be great. All the people who have eaglet ESP will get the upgrade for BostonSight. And my fit report is it allows us to get patient-generated health data that is free, and it allows us to basically monitor our patients and other patients' experiences with the BostonSight Scleral. And we'll get more into that in a minute. But Fit Assist is also, I think, such a generous endeavor by BostonSight. Basically, when you fit 12 patients with BostonSight, they give you a voucher for a free pair of lenses. And so that is amazing. You know, we all have patients who need scleral lenses, who can't afford them or who don't have insurance. I know I have a lot of them. And so it's great, to be able to give back and give them the opportunity to use such an amazing lens, and to have the opportunity to have scleral lenses. And these vouchers never expire, so you can use them anytime as you accumulate them. So a little bit more on my fit report. My fit report is, it allows you to get feedback on your patient experiences. It's really easy for your own practice to participate. And actually patients get a complimentary scleral lens emergency kit when they do. But really what it does is allows you to get patient-generated health data, as I mentioned before. And when we look at some of the data from my fit report that we see, this is just satisfaction. So green is the patient's satisfaction prior, so in their prior modality. And we can see the increase in comfort, satisfaction in vision, and overall. So there's actually a 65% increase in comfort, a 56% increase in vision satisfaction, and a 59% increase in overall satisfaction. And these are on a scale of 1 to 10. So we can see a huge change from previous. And we all know the OSDI. This is the Ocular Surface Disease Index. It's a subjective questionnaire that we give our patients to determine how much dry eye is affecting their lives. The higher the score, the more severe it is. And we can see here previously and after using the BostonSight lens. and you can see that there is a 57% decrease in OSDI score. So that's awesome if we can, improve the patient's dry eye symptoms as well. So I'm going to hand it over to Steve. I think you wanted to talk a little bit more about some of the technologies.
Sure. Thank you, Elise. So we're going to talk a little bit about some of the benefits of the BostonSight lens. The main thing that I wanted to touch on is this spline curve technology, which really allows you to make independent changes in different parameters. In other words, if you wanted to change the vault, you don't really have to adjust anything as far as compensation with the base curve or the limbus as well. The quadrant-specific toric system, Elise, elaborated on that very well. Smart channel technology was recently introduced for the BostonSight Scleral. It's been available for the Pros lens for a while. This allows you to create channels to avoid certain obstructions, either on the cornea or the conjunctiva. Lens diameters, Elise had touched on the 3 different diameters and the 22 lens set, and beyond the fit, which is consultation. So this is the original patent that Perry Rosenthal, the late Perry Rosenthal, had introduced way back in 2008 for the channels, and this allows fenestrations and allows you to, again, to get rid of obstructions in the cornea or the conch. The Fit Connect, we had just touched on that a few minutes ago. Basically, it's really helpful to have everything graphical. We'll talk about that as we go forward, but it's great to be able to program these things in, see what's happening in real time, and allows you to communicate directly with the lab and see what's happening with your lenses, and also tracks your orders and your delivery dates and returns. All those things are very, very easy to do. Next slide, please. Okay, so there's the Fit Connect dashboard. So you have many different things going on there: the name of the patient, the right and left lens, the order number, basically the RX status, where it is. You can click on that, and at the bottom there, it shows you the actual lens order itself, and you can click on the next slide. And this is the real-time graphical analysis with the different 4 haptics. As Elise had said, you can click on plus and minus. What's helpful is you can see with that graph there, if you increase or decrease, what you're exactly doing to one specific parameter. So you have the 4 different meridians with the 4 different zones of changing independently or together, depending on what you want to do. At the bottom left there, you'll see that there's a sag. You can do increase and decrease. You could also adjust the base curve as you go. So this is very helpful when you're designing a lens to see what kind of changes you're making as you're going forward. Next slide. And this is just more of a graphical analysis, elaboration of what we just spoke about, where you could either increase or decrease different parameters. There's the sag, central sag there, and then at the bottom left, you see what you're doing, and then of course the base curve itself parameter as well. Next slide. Okay, so we're going to hand it back over to Elise now. She's going to start with some of our cases, and then you'll be back to me afterwards.
Yeah, so I'm going to go through some cases in which, for me, when I use the BostonSight, it really improved my patient, how satisfied they were. In general, a lot of the cases are a little bit more advanced, but they're really interesting. And in this case particularly, this is a 48-year-old Hispanic man who came in. He was already wearing scleral lenses. He had RK 25 years ago. So, patient, it's one thing if you have a patient who's never worn scleral lenses before and he has RK and you put on the scleral lenses and it's like, wow. But if you have a patient who's already wearing scleral lenses, then you have to somehow wow them because they're coming to you for a reason. And see if you can do better than what they have already. So this patient was wearing scleral lenses, as I mentioned. His visual acuity was 20/25, 20/40, but his main complaint, let me see if I can change this. There we go. So his main complaint, and you can see the RK scars here, is just, his eye was just so red. And he couldn't tolerate the lens for many hours. So he was not happy with his current scleral lenses. Also, he said that the vision could probably be better, but his main complaint was just that the redness and just could not tolerate the lens. And you could see how angry this eye looks. You could see blanching here. And so when we look at the parameters, we see that the patient does have a front surface toric here. And when you look at the bottom of the chart, you can see that there's prism. And so that tells me that this patient is wearing a standard scleral lens. He's wearing a standard scleral lens that is being stabilized with a prism. And so, of course, you do that, and it just in an eye that is not standard, it just can lead to a lot of complications. And so what we did is we did an OCT, and you could see, that this eye is definitely not symmetric. So going back here, what I did is I put on a BostonSight lens on this eye, and obviously with the BostonSight, it's really simple to modify different quadrants. We can see here, especially this zone here where you definitely have compression. So it's easy to flatten just this one area, and basically the patient, and basically what you have here on Fit Connect is the ability to really just modify the exact meridians you want. Zooming in, if I wanted to flatten this meridian here, I could just do that. And here, what I did is I flattened it by 250 microns in each meridian, and the patient did so much better. If you look at this eye here, it just looks so much better, and we expect it to continue to improve. So just such a huge difference, and so simple to troubleshoot this with the BostonSight Scleral. So also what we have with this lens is the ability to minimize modifications, reduce the number of patient sessions. I mean, I was going through the fitting process, the fitting algorithm earlier, and I was showing you guys how you can really do this in almost one visit sometimes. And so the second case I want to bring is a 68-year-old white male who came. He came for a scleral lens evaluation. He was referred by a cornea specialist. He had radiation therapy, or was undergoing radiation therapy actively on the left side of the face because he had squamous cell carcinoma, which was still active. And with that radiation therapy, he did have an atrophy of the lacrimal glands. He also had multiple eyelid procedures done because he had exposure. So he had grafts around the eye, he had tarsorrhaphies, I think he had at least 3, and he also had gold weight implants. So he had a bunch of stuff done, and I'll show you a picture here. And I don't even think this, anterior segment image does it justice, but you can see a lot of irritation here on the lower cornea, and the patient could just not close the eye completely. So you can really see that even this is the most he could close his eye, and you could just see that area of exposure. So a patient who has exposure keratopathy, I mean, obviously they're not neurotrophic, they're feeling everything, and this patient was just miserable. He was seeing fine, but he was just really miserable because he was in a lot of pain. So we actually put a BostonSight lens on this eye, and you can see this is the number 5 lens that I put on the eye, and the patient did amazing. I mean, you might have to modify a few haptics here and there, but really just with the lens and an over refraction 20/20, patient super happy and suffering a lot less. So I really happy I was able to help in that case. The third case I have is a 71-year-old white male. He came in for a scleral lens evaluation. He did have toxoplasmosis in the left eye, no more central vision, but he was actually also wearing scleral lenses when he came to me. So we're not going to get into retina, obviously, but he had no central vision from toxoplasmosis. His vision was about 2400 in that eye, but he needed to wear scleral lenses because he had Sjogren's syndrome really bad. He was suffering a lot. He was on Plaquenil and really the kitchen sink of dry eye treatments, artificial tears, serum tears, steroids, punctal plugs, you name it, and still suffering. But again, you taking a patient who's already wearing scleral lenses and you want to improve the situation, you need something that is very customizable. And this patient, he was just saying, listen, I need my scleral lenses because I'm in so much pain. My eyes are so dry, but I really just cannot wear my lenses for more than an hour. They're dirty, they're foggy, they're uncomfortable. So we take a look at this lens and I'm like, okay, I know why this lens is uncomfortable. It's coated with lipids, proteins, it's dirty. So the patient just was not having, he was not able to tolerate this lens. So what's great about the BostonSight is that we do have the ability to put HydraPeg, and tangible HydraPeg is an awesome technology that increases the lubricity of the lenses. It increases their ability to interact with the patient's own tears, reduces the amount of protein and lipid buildup, just making it overall more comfortable. And also sometimes, you can imagine with a lens that looks that dirty, the patient is just not going to be seeing well either. So we did put HydraPeg on this lens, and you can really see the difference there. The patient was so much happier. He did really well and was able to wear his lens for a lot longer. So again, in this case, you're really just you're upgrading, what the patient already has and improving their satisfaction by using all the technology available today and the customizations by BostonSight that are available and easy to just do through FitConnect. So that is another great case. So I'm going to pass it back to Steve. I think you wanted to share some cases as well.
Yes, thank you, Elise. So my first case I picked was a keratoconus patient. You can switch to the next slide. We haven't talked about keratoconus much, but obviously for scleral lens fitters, that's sort of our bread and butter. Predominantly what I see in my practice. And the case that I chose was actually a new novice contact lens wearer. He was diagnosed with keratoconus. He's 18 years old. His left eye, he noticed decreased vision over the past couple of years, so his primary care doc referred him over to our office. You can see his uncorrected acuities are counting fingers in both eyes. Next slide, please. And this is his orb scan of his right eye. You can see obviously significant keratoconus. I know it's small probably on your screen, but his steep K in the right eye was 68. So, it's a pretty significant keratoconus for an 18-year-old that was not previously diagnosed before. And next slide will be I believe the left eye. And very similar, not the greatest quality, but steep Ks of 64. So we're dealing with a pretty moderate to almost severe level of keratoconus in both eyes. Next slide. So refraction, right eye we're able to get into 20/60, left eye was really no improvement. Clinically, really just some central striae, nothing too unusual there. His HVID of note was 12.1 in both eyes. So obviously the first step in an 18-year-old with progressive keratoconus is to do collagen cross-linking, which was performed. Afterwards, he came back to me for his contact lens fit. Next slide, please. Okay, so 2 weeks post-op, he was doing fine. He re-epithelialized. We pretty much do all epi-on cross-linking, so he's ready for contacts pretty much right away. We talked about obviously, multiple contact lens modalities, but since he had such a severe keratoconus, we decided to go jump right into scleral lenses. Next slide. So being that he had severe keratoconus, we fit him with the BostonSight lens. I decided to go with an 18.5, which is sort of middle of the road diameter, and we used the 5, the middle of the road lens as well with the the E1 eccentricity. We let the lenses settle for 30 minutes, and we got that plus 275 over refraction, which got him to 20/20, which in a 68K was quite amazing right off the bat. Nice 228 central thickness, right? Central vaulting, and we did note, which I'll show in a slide or two, that his mid-periphery was vaulted a little bit too much. The alignment was good right off the bat with the lens. Next slide. So this is the OCT of the right eye, which showed it's very small. Again, you probably can't see it, but it's 228 microns after that 30 minutes of settling, so it looked nice. Next slide. And which is interesting, the left eye also showed exactly a 228 microns. So I don't know how that worked out, but it was pretty cool that both eyes were actually, exactly the same as far as the central vault after that 30 minutes of settling. Next slide. And I believe the next slide is the increased mid-peripheral clearance there. So I did want to drop that down a little bit, which I'll show you in a moment. Next slide. So the left eye had, other than the central vault being where we want it to be, the mid-periphery was actually good in the left eye, and the haptics also showed good alignment. There was no impingement or edge lift at all. So what we did is we utilized Fit Connect, which I talked about before. This is really a great way to streamline the process of designing lenses, where you can see on those graphical analyses what you're doing with different parameters with the lens. And as Elise had said, there's really not that much you can do with the BostonSight lens. Everything's pretty much built in. So really you can adjust the base curve, you can adjust the vault, and you can adjust the haptics. That's really it. So it's a very, very straightforward way to fit lenses. So I did elect to steepen the base curve in that right eye to sort of drop down the mid-periphery. Also, since we got a plus 275 over refraction, changing the base curve will decrease the power a little bit. So next slide. So we ordered the lenses, and right off the bat, 20/20 vision in both eyes with the E1 eccentricity. So right at that standard eccentricity, with the BostonSight design and the optics of the lens, 20/20 vision for that level of keratoconus, that was quite amazing. We saw him back for 2-week follow-up. He's wearing the lenses 14 hours a day. And again, this is someone who's naive to contact lenses and especially naive to scleral lenses. Right off the bat, he was so excited to see. He was functioning really, really well. Saw him a month later, no changes in RX, and he was ready to go. So one lens, new patient, severe keratoconus right off the bat. Within a couple of months of having cross-linking, he basically got his life back, an 18-year-old that's ready to go to college. Next slide, please. So this is just a slit lamp image of the lens on his eye, which showing nice uniform post-lens tear layer. Everything looked wonderful right off the bat. Next slide. So to wrap up this case, we actually purchased a pentacam in between getting the initial images before it's cross-linking. So I wanted to just show you the pentacams afterwards. This is sort of the state of the art now as far as imaging of the corneal surface. So his corneas did flatten about a diopter or two after the cross-linking, which is what we typically will see at this stage of the game. So his cornea did flatten a little bit. Next slide will be the left eye. So just a little bit of flattening in both eyes after having the cross-linking, and he's doing well. Next slide. So just to wrap up with this one particular case, he was a post-cross-linking patient, he had severe keratoconus, one lens order for each eye, minimizing patient visits. He's a high school kid that plays sports or wanted to play sports and was very active in school. So this way he didn't have to come back and forth 8 or 9 times. We got it done within 3 or 4 visits. The process was easy with the Fit Connect, very straightforward, and the built-in Scleral Shape and the laterality basically allows us to fit these patients in a much more efficient manner. Okay, next slide. And I'll now work on a different case, which was quite challenging, as you'll see when I talk about the history. This patient was very sad. He was a construction worker. He had alkali chemical burns secondary to this accident. So basically, he was in the burn unit at our local hospital for a long period of time. He developed very severe ocular surface trauma and also lid, which is very, very challenging. Matarosis, basically lost almost all of his lashes. He sees plastics, every 4 to 6 weeks between myself and the plastics doc, taking out lashes, aberrant lashes that were there. You'll see in a slide that I have going forward, he had significant conjunctival scarring, some blepharon, and corneal scarring as well. He did have some eyelid surgeries along the way. He had some conjunctival autograft, PTK surgery, amniotic membranes, to try to minimize the damage, but his corneas were pretty messed up. So he was ametropic before the accident, and now he's 2400 at this point. Next slide. So I had fit him with, we originally had tried corneal GP lenses for a very short period of time. They really were not successful. So I fit him with scleral lenses about 5 years ago. And he did reasonably well. He got to about 20/40 vision. I was able to wear the lens, but they were never 100% comfortable. He was getting redness, he was getting irritation with the symblepharon and the scarring. But we gave him his life back, so he was appreciative, and he was able to get through. So I'd see him every 6 months or so for his follow-up visits. And finally, when the BostonSight lens came out and was available, we decided to refit him into a lens and say, hey, look, there's new technology now. Let's try something new. So he is taking some Predmild and erythromycin ointment, the lids, basically for the lids and for the corneal scarring. Next slide. Okay, so I put on the 18. See, this is the R18 there. Because his conjunctiva was so scarred, he had some symblepharons, there. I figured the smallest lens would be better for him. So we put on the diagnostic lens, and what was amazing is I got a plano over-refraction, got into 20/25 -2. If you remember his previous lens that he's been wearing, he only got to 20/40. And what I find interesting is that with the Boston lens, it's very rare that I get a very high over-refraction. Some other lens designs are getting -8, -9 or so, or plus. But in this case, we got to plano, and I find that because of the eccentricity and the optics and all the knowledge and experience that they built into this lens, it's very rare that we have to go very high with the over-refraction. And I've had plenty of patients, including this one, where they said, oh, can I just take this lens home? I'm already seeing so much better. Can I just take this lens home with me? So it's an interesting aside. If those of you who fit the lens already, or those of you who are thinking of fitting the lens, is something that is an interesting and an excellent property of the lens. So this had good central vault after the settling. The limbal clearance was good as well. We did have that symblepharon, which we had to deal with, but other than that, the overall appearance of the fit was actually very, very good. Next slide. So this is a picture of his cornea, and you can see all that scarring lipid. And his cornea looked much better after all these surgeries. When I saw him, 5, 6 years ago, it was much, much worse. His cornea actually has improved over time. Unfortunately, we can't get any topographies on him because his corneal surface is so irregular. So we basically just, you put lens on and you go from there. And even with all that lipid and scarring, again, it's amazing that you can get a lens on that eye and get him to 20/25. You can see the lid, all that matarosis, there's like one lash poking out, but the remainder of the lashes are gone. Next. So I did call into consultation just to sort of help, get helped out a little bit on designing this special lens with a superior notch. We dispensed the lens. He's doing really, really well. Appreciates the better vision. He appreciates the better comfort. Cosmesis is better as well. We did put a hydropeg on the lens as well because of his lack of his dry eye and the lid pathology that he does have. Next slide. So this is a picture of the lens on his eye. You can see the upper left corner there that there's that symblepharon, and we put that notch in there. His eye is never going to look pretty, of course. There's always going to be some redness and inflammation that's there. But with the lens on, he can wear it 16 hours a day. He's back working as a construction worker. He's very appreciative. We definitely, change people's lives, especially something like this. Next slide. And this is just another picture of the lens on the eye, where you can sort of see that notch there. And as Elise had mentioned earlier, you see the one dot for the right lens. So this is a right lens. There's 2 dots if it would be a left lens. Next slide. Okay, so to wrap up this case of mine, BostonSight lens allowed me to fit a very, very challenging eye, and a patient who was reasonably successful with scleral lenses in the past. But this way we were able to get them down 2 lines in the chart, better cosmesis, better comfort, and it was a really, really nice story. And the patients, of course, very, very appreciative. And that's it for my second case. Well, thank you guys so much for listening. And I'm sure there are probably some questions that you guys may have or thoughts. I think, Alan, you're going to be mediating this part.
Yes, thanks a lot, Dr. Sorkin, Dr. Kramer. One question, actually, Dr. Sorkin, if you don't mind me asking,
Sure.
is how soon after cross-linking do you normally proceed with a fit, scleral lens fit if necessary?
Yeah, so our office does pretty much exclusively epi on, so we'll see them a few days afterwards for a post-op visit. At about 2 weeks or 3 weeks, I'm usually getting them into contact lenses at that point.
Oh, okay.
There's really there's no real lag time. If it's epi off, you really have to wait, 6 to 8 weeks probably. But since we're not really doing that much anymore, it's pretty quick. Like this high school kid that we were talking about,
Right.
I saw him 2 weeks, and we did the fitting, and obviously took a week and a half till he got back into the office. So by that point, it was closer to a month. And then you saw from the last set of pentacams that his cornea did flatten out a little bit, and that's where you have your 3-month 90-day warranty if you have to make any last-minute adjustments. A practice management thing I would say for any patient is I usually like to see them back just about that 90-day mark, just for a final evaluation, just in case we have to make any last-minute adjustments for any reason. We're still within that 90-day mark.
Yeah, that makes sense. Another question that was posed, and I just want to address it here, is was regarding the location of the dots, and the meridians are also marked. The superior one is 1, the one off to the right, either nasal or temporal, depending on which eye, is 2, inferior is 3, and the one on the left is 4. And typically, about 6, what we have found, and I don't know if Dr. Kramer or Dr. Sorkin can support this, but typically the dots will reside supranasal. So in the right eye, it'll be up at around 1 or 2 o'clock in our perspective, the clinician's perspective when we look in the slit lamp, and in the left eye, it'll be around 10 or 11 typically when we're looking in the slit lamp. The left eye has 2 dots. The dots are mostly to indicate right and left, and the location, like I said, generally resides there, and it doesn't necessarily indicate a steeper or the steep meridian or flat meridian, but it's just the meridian that we tell the patient to put in superiorly, mainly so that it's hidden underneath the lid, so that it's not visible to others. Hopefully that makes it a little more clear with regards to that. Thank you so much, Dr. Kramer and Dr. Sorkin, for sharing us your experiences and your insight. And if anyone has questions, by all means, you can email us at the email that's shown here, bostonsightscleral@bostonsight.org. And for those who haven't registered, you can do so easily by going to FitConnect at fitconnect.bostonsightscleral.org. And you can also email us, and we'd be happy to reach out and help you register as well. And finally, as I mentioned earlier, this webinar is being, there it is. This is the FitConnect Boston Sight Scleral website where you can register for an account. And as I mentioned earlier, this webinar is being recorded, and you will receive a link to this recording once it's completed. And any unanswered questions will be answered separately, and we will try to get back to you for the questions that we weren't able to answer here. And that concludes this webinar. Thank you again to our speakers and for all of you who have attended, and we look forward to seeing you at our next one, which I believe is in May. May of 2019, August, and also October, but the next one will be in May. So thanks again, everyone, and have a good night.